everybody. I would like to introduce Dr. Laura Han, who was previously at the University of Melbourne. She is an expert in working with ENIGMA MDD data and has worked extensively with that huge data set. I'm so happy to have her here. She is also an incoming assistant professor at the Amsterdam University Medical Center. It's going to move there soon. So yeah, with that, I'm excited for your talk.
Yeah, thank you so much, Katarina. I'm so happy to be here. I'm a bit more nervous than usual for this talk. So my partner, who is not in academia, has weaseled his way into the room. At least it's good to know there's one person who'll be laughing at my jokes. Next slide and back to business. I'll be talking about brain age and major depressive disorder and genetic and environmental risk and resilience factors. So our societies are actually facing two major challenges: high rates of depression and an increasing aging society or population. Depression is one of the largest leading contributors to the global disease burden, and recent studies show that mental disorders may reduce the life expectancy up to as much as 20 years. But this is primarily due to deaths from preventable physical diseases. And so we can think about diabetes or cardiovascular diseases. And for example, the risk of developing cardiometabolic disease is around 40% higher in persons with mental disorders or stress-related disorders compared to the general population. And I think if we can understand the biological basis of aging or biological aging and can identify the mechanisms by which depression or stress-related disorders may drive biological aging, we may find ways to prevent, halt, or delay abnormal aging trajectories. So I'm sure everyone is familiar with the brain age paradigm. We've seen a lot of it in the posters this year as well. But very briefly, chronological age is just a strong but a very imperfect risk factor for mortality. And persons with the same date of birth can actually vary considerably in their health and in their lifespan. And brain age algorithms have kind of emerged as a tool for studying these inter-individual differences in aging. And what happens is you train an algorithm to predict age from brain scans in sort of a normative population, and then apply that algorithm to a different population from which you do not know the age label, such that you get a predicted age based on the brain scan. And a positive value may imply that you're biologically older, and a younger value may imply that you're biologically younger. And I've been lucky to work together with a wonderful team in developing a brain age prediction model from ENIGMA major depressive disorder consortium data. And with access to their data, we actually had about 19 different cohorts available, totaling to about 7,000 imaging derivatives from almost the entire adult lifespan, so 18 to 75 years old. And some main characteristics of the model. So we used the DK atlas in the FreeSurfer for the cortical parcellation, and the ASEC atlas for the subcortical segmentation. And we used the left and right features of cortical thickness, surface area, subcortical volumes, the lateral ventricles, and intracranial volume. And we then averaged those over the left and right hemisphere. And this resulted in 77 input features to predict age. And we built separate models for males and females, and then trained a rich regression with tenfold cross-validation, and then applied the trained coefficients to half of our holdout sample of controls and patients to compare the brain age gap between controls and those with depression. And using such method, we found that patients with depression were estimated to be about a year older than control subjects. But as you can see, what's very evident from this figure is that the effects are rather subtle and substantial within group. Variance and overlap between the groups was observed. And in other words, if you can yeah, it's not very useful as a biomarker to distinguish cases from controls at all with a small effect size of 0.14. So with the help of Ramona Lenings and Tim Haan, we actually made this model publicly available in the form of a web-based tool. So if you pre-process your images, your T1 weighted images according to the FreeSurfer pipeline and the standard ENIGMA QC protocols, you can extract the features and upload the CSV files to this website, and it will generate brain age predictions for your sample. And applying this model to many different data sets around the world, we find that the model generalizes reasonably well to independent cohorts, and it has demonstrated quite a bit of clinical validity as well by being able to pick up on several case control differences in different kind of groups, with a slightly larger effect size, I think, than when looking at just structural brain measures directly. And it has some associations with psychopathology as well. So yeah, as you've seen in this conference, I think a higher brain age gap is not specific to depression. It's more of a general kind of transdiagnostic indicator of compromised brain health. And we've seen effects there and case control differences in other psychiatric disorders such as schizophrenia, bipolar disorder, specific phobia, and other, for example, medical emergencies that impact the brain, like stroke. And I think taken together, the magnitude of the brain age gap in psychiatry or in psychiatric disorders follows a quite consistent and very similar pattern that is consistent with other structural brain findings, so bigger effect sizes in, for example, schizophrenia, and then smaller effect sizes in bipolar disorder and depression and anxiety. And because we always have new cohorts joining the consortium as well, we had 13 unseen cohorts available that joined the consortium later than the development of the model and the initial paper. And so we were able to replicate or run a replication study on these new samples, and by doing that, we found we took both a mega-analytic and a meta-analytic approach, and we found very similar brain age gap in depression and a very similar effect size, Cohen's d effect size as well. So we replicated the gap. Again, it's very it's robust but very small, subtle, and if you have a look on the right-hand side at the meta-analysis, you can also see that there's quite a bit of heterogeneity across sites as well. And important to point out again is that there's much overlap between the groups of controls and persons with depression, so substantial overlap there. Yeah, so robust but subtle, age-related structural brain patterns, but a replicated gap of about a year. The small pooled effect may in part be driven by the heterogeneity across scanning sites. But when we looked at some basic patient properties that we had available within ENIGMA, so for example, an acute or a remitted depression or a first episode or recurrent depression, we didn't see any differences between those patient groups and the brain age gap. So even though there's a higher brain age gap in depression, I think, and that might have a potential explanation for the increased risk of premature mortality that we're seeing, I think brain aging and depression are both individually already very complex phenomena, and so are their interactions. So I think it highlights the important need to further dissect the nature and direction of the connections. So for example, it remains relatively unknown whether a higher brain age gap is a cause or a consequence of depression. And by looking at the genetic vulnerability for example, depression and depression-related characteristics, this may provide some additional insights into this. Furthermore, I think depression is a condition in which poor lifestyle, inflammation, obesity, and then aging processes co-occur and converge. And so we hypothesized that there were some characteristics related to unfavorable metabolic profile that might tie together the observation of a higher brain age gap in depression. So to investigate some of the genetic bases, we used polygenic risk scores that are DNA-derived estimations of genetic liability. And so polygenic risk score is a way to estimate a person's genetic risk for developing a particular trait or a disease. And it combines information from many different genes to estimate an individual's overall genetic risk for that trait or disease. And for example, if you have a large discovery GWAS, they might have identified 100 alleles or genes that are contributing to a particular disease or trait. Then we can use this information to calculate a polygenic risk score for each individual person based on which versions of the genes that they have. And someone with many of these risk-increasing genes or versions of these genes will have a higher polygenic risk score for the trait or the disease. And so we used methods for calculating polygenic risk scores in ENIGMA MDD by using protocols that were developed by Shen and tested by Yara and me. And it's good to mention that participating cohorts within ENIGMA MDD consortium are not at liberty always, because there are clinical case control studies to share data or to share genetic data. This was really a protocol in a way that we were able to calculate polygenic risk scores for these cohorts without having to share any or get access to any of their genetic data. So participating cohorts calculated the polygenic risk scores themselves using these protocols and shared them, the summary statistics with us. It incorporates GCTA and PRECISE to calculate polygenic risk scores, and we included summary statistics for depression, BMI, and CRP, according to a clumping and thresholding method. So to validate the findings of the polygenic risk scores, we first checked within our samples whether the calculated genetic risk, so the polygenic risk score for depression, was actually predictive of the depression phenotype. And so here we can see that for, here we can see that for 7 out of the 10 thresholds, indeed, the polygenic risk for depression or the genetic liability for depression also predicts the phenotype of depression. And when we look at the most optimal threshold here, and we use that threshold to associate the polygenic risk with the brain age gap, we also find that a higher polygenic risk for depression predicts a higher brain age gap. And not only for the optimal threshold, but also for 3, or in total 4 out of 10 thresholds. So this, I think, adds robustness to our findings. So we repeated this, and the same was done for BMI, and that polygenic risk score actually showed validity across all the 10 thresholds. So the polygenic risk score for BMI predicted BMI in our samples for all of the thresholds. And then when we look at the most optimal threshold, we found an association again between the polygenic risk score for BMI and a higher brain age gap. But here you can see that it's only we could only identify that for only 1 out of the 10 thresholds. Finally, because we also wanted to examine potential underlying biological mechanisms related to inflammation, we looked at the polygenic risk score for CRP, or elevated CRP, which is more stable than looking at fluctuating peripheral CRP levels. But also, we didn't have a lot of CRP data available within the consortium that we could harmonize effectively. And so we couldn't validate whether the polygenic risk score actually predicts CRP in our samples, but it definitely predicts CRP in other samples. And when we when we look at the polygenic risk score in our samples, we see that for 5 out of the 10 thresholds, we actually see an association with more elevated inflammation associated to a higher brain age gap. And it's good to mention that for all of these associations, there is no interaction between this variable and diagnostic status. So the analyses are carried out across groups, both controls and patients. And when we further looked into environmental variables related to lifestyle exposures or adverse experiences, we also found that the BMI phenotype itself, childhood trauma, smoking, which is a current status of smoking, were associated with a higher brain age gap, whereas education was a protective factor and more years of education was associated to a lower brain age gap. And then for the genetic liability of BMI, we can see here that it wasn't so robust and actually is non-significant when corrected for multiple comparisons. And when we input kind of all the variables into one multivariate model to look at the unique and the shared variants in brain age, we show that the genetic liability for inflammation and childhood trauma also became non-significant. So to sum up, we found that specifically the genetic liability for depression, the BMI phenotype, so being having a high BMI and smoking status, can potentially be considered risk factors in the context of this symposium, and education potentially as a protective factor in multivariate analyses. So conclusions and future directions, I think that using these standardized protocols and algorithms, we can use them locally or send them, distribute them to participating cohorts so they can run these analyses locally and share only the summary statistics with us. So we can have a mega-analysis on brain age and polygenic risk. And we were able to explain the individual differences in the brain age gap a little bit better. And we find robust evidence across 12 cohorts that a higher brain age gap in depression is, and at least in part, has a genetic basis for depression or associated with a genetic basis for depression as well. I think findings also suggest that there's a stronger lifestyle management rationale for the treatment of depression. So not only when we think about reducing the psychological symptoms of depression, it might be fruitful to look at, for example, smoking cessation or weight loss, and or at least potentially weight loss may improve then not only the mental health but also physical health outcomes and potentially also brain health. And this is a plug for, if you're interested in this space, we are running a clinical trial looking at running therapy and antidepressants in the treatment of depression and anxiety disorders. And we will be looking at the brain age gap in this context as well by looking at the effects of running therapy. And I think overall, this is a nice example, or this study is a nice example of how we can use findings from large-scale studies and then use that to inform clinical studies that have better or are more deeply clinically phenotyped about ways to, for example, stratify groups. We are also running some exploratory analyses here by looking at the genetic liability for epigenetic aging, so another biological age indicator that is based on DNA methylation data. So previous studies have shown higher epigenetic aging in depression in both blood and post-mortem brain tissue, although there are also some inconsistent findings reported in different samples or only with specific symptom domains. There's also a study showing that the combination between brain age and epigenetic age improves mortality risk prediction. So a question here is the peripheral epigenetic aging also related or synchronized to central brain aging? And this is work to be continued, and hopefully I'll be sharing these findings very soon. I absolutely did not do all this work by myself, so I really want to emphasize that I want to thank all the research participants, the ENIGMA MDD working group contributors for sharing their data and participating in team science here. And I want to thank Katharina for organizing this symposium and inviting me here. Very happy and to take your questions as well. Thank you.
Yes, please come up if you have questions, or put your questions in the chat. That should work too.
I have a question that concerns the brain age gap and whether that's a trait or something that's dynamic. Do you have any longitudinal data where we can better understand if the brain age gap is something that participants retain throughout their lives, or it's something that's actually impacted by environmental differences or differences in their medical history?
Yeah, I think that's a very good question, a very relevant question that we're looking into. I think there are several different brain age models out there that have looked at, or several brain age studies using different brain age models longitudinally. And some of them actually show that it's indeed more related to kind of vulnerability markers and has a better genetic kind of underlying, it was more explained by genetics and does not really track aging rates over time longitudinally. But I think we mustn't forget that there are different brain age models out there that are trained on different features, and so not everything can be categorized as brain age. I think for myself, when I look at clinical trial, I had a poster Monday and Tuesday using also a different brain age model based on a deep learning model by Leonards et al. We actually found that brain age, at least within a clinical trial perspective, so baseline 3 months and 12 months later, was quite stable. So both in control samples as well as patients receiving lithium and quetiapine treatment. But this was a quite relatively limited sample size, so we couldn't detect any change over time there. But I think, I expect that it would be changeable. Thank you.
Hi, really interesting talk. I was wondering if you're able to look at differences in brain age across depression subtypes. So for example, like adolescent versus adult onset, treatment resistant versus like more episodic depression. Because I know that in ENIGMA MDD, you do have that data. Is that something that you looked at or thought about looking at?
Yeah, thank you so much. It's very interesting. I think we have quite limited information available in terms of patient and clinical characteristics. We did have a look at, for example, an early onset or a late onset of depression, and we couldn't do like the gross group comparisons. We didn't find any differences there. But I think that what's exciting is that we have this algorithm that's developed, and then we can apply into clinical case control studies or other well-phenotyped studies where we can look into this in much more detail. So for example, within a Netherlands study of depression and anxiety, we had a look at a couple of these things, and we didn't find any associations for that, but we did see, for example, that people that were using antidepressants had a lower brain age gap compared to people that were not using antidepressants. Potentially showing neuroprotective effects, but also was a naturalistic cross-sectional study. But we will be looking into that in the motor study as well for antidepressants. Thank you.
We have a bunch of questions in the chat. Do you want to come here and have a look with me?
Yeah.
I don't think we can go through all of them, but there's a lot of more theoretical questions. You can pick and choose.
One question is, did you check any other models besides the rich regression model that you used? Yes, we actually compared several different algorithms. So we looked at support vector machines, and we also looked at Gaussian process regressions. But I think what's important to realize there is that in some ways the model stores individual level data to actually, for example, the support vectors. And so that would mean that if we would share the model publicly with other people, individual level data of the training data would be a little bit stored within the model. And so for the rich regression, it was only underperforming slightly, but here you can just share the coefficients to make new predictions that are completely, do not have any information available about the training data. So, but yes, I think in short, the Gaussian process regression with a nonlinear kernel performed slightly better. Does age matter for the relationship between the brain age gap and inflammation? I think it does matter, and we also will be looking at young and adolescent populations as well. So the YODA study that there is available at the University of Melbourne, looking at anti-inflammatory medication in the treatment of depression in adolescents. There we would be using a different brain age model because this one is trained on the adult age range. Have you looked into whether different features other than free surfer morphometry measures would change the brain age difference? So we've done at some point a quite small comparative study looking at vertex-wise, VBM-wise, and also free surfer ROI derivatives at brain age prediction. But even though there are different performance accuracies, of course, associated with it, haven't compared it in the case controls, I think. Have you looked in? Well, we also compared a VBM-based brain age model head-to-head in some subsamples within ENIGMA MDD, and we actually found that although the distribution or the standard deviation of the predictions was smaller, the mean was actually very comparable to the free surfer-based model.
Okay, great. I have two closing remarks. Thank you so much for coming. If you have data on task-based stress resilience, fMRI, there's a new ENIGMA working group. Sorry, what?
I think you can upvote questions, and I was starting from the bottom, but probably should start with the...
That's fine, that's fine. We're like over time anyway. You're good. Anyone who hasn't gotten their question answered, please reach out directly to Dr. Han and she will answer. But as I've mentioned, there is a ENIGMA resilience working group that's starting out. So if you have data and you want to contribute, I think you can email them. Lastly, I want to talk about the effect of education. I think it's remarkable that you see the effect and it's so far-reaching, right? Because if you have more education, you're better able to make health decisions. You're also more likely to have a higher paying job. So there's like and then with more income, you're able to buy better health care. So there's like a large effect of education that's really interesting. And with that, thank you so much for coming and have a great rest of your day. Thank you.